Welcome to this explainer. Okay, today we're diving deep into the mystery of that dreaded morning heel pain. If you're an athlete or just someone who's on your feet all day, you probably know exactly what I'm talking about. We're going to uncover how doctors track down the culprit behind this, treating the whole diagnostic process like a high-stakes medical detective story. Let's get right into it.
Seriously, have you ever felt that literal stabbing pain with your very first step out of bed? You know the feeling. But what's actually happening inside your foot to cause that intense, sharp pain? Well, to find out, we really need to examine the evidence.
So here is our diagnostic roadmap for today. We're going to look at the morning heel pain, the anatomy of the arch, wear, tear, and overuse, the clinical examination, seeing beneath the skin, and finally, ruling out other causes.
All right, step 1, the morning heel pain, or as I like to call it, the scene of the crime.
So the absolute classic symptom that brings patients limping into the clinic is a very localized pain at the inner bottom of the heel. Medical professionals call this the medial plantar aspect. The real telltale signature here, that pain typically peaks during your very first step out of bed or right after you start moving again after chilling on the couch for a while. The weird part is it actually gets better as you rest it or even as you warm up a bit.
Moving to step 2, the anatomy of the arch, our primary victim.
To truly understand why this hurts so much, we got to look at the hardware. The plantar fascia is this incredibly thick band of longitudinally aligned collagen fibers running straight from your heel bone all the way to your toes. It's actually divided into 3 parts: medial, central, and lateral. That central portion, it is super thick and strong. It basically acts as your foot's built-in shock absorber and is absolutely crucial for passively stabilizing your arch. But listen, it's not just some static rubber band. There's this fascinating dynamic concept called the windlass mechanism. Think of it like a mechanical tension cable in a crane. When you pull your toes back to push off the ground, which is called toe dorsiflexion, that fascia tightens right up around the joints. This tension jacks up your foot's arch and transforms your entire foot into a rigid lever. That is exactly what gives you such an effective transmission of force when you run.
Okay, step 3, wear, tear, and overuse. This is the real motive. Here is the massive twist in our detective story. We constantly hear the term plantar fasciitis, right? And that itis at the end literally implies an inflammatory disease. Well, plot twist. Modern science has totally rewritten the case file. When researchers actually look at the tissue, they find it's primarily an overuse and degenerative issue. So it's technically a fasciopathy. It's not just simple inflammation, it's repetitive mechanical stress causing a buildup of microscopic tears, which leads to collagen degeneration and structural fatigue. But, old habits die hard, so doctors and runners still call it fasciitis all the time.
So what's actually causing all these micro tears? If we build our suspect profile, a few huge risk factors jump out. Having a BMI over 30 puts a ton of sheer mechanical load on that tissue. But get this, limited ankle flexibility, specifically having 0 degrees of ankle dorsiflexion, is associated with a massive, huge risk increase. Combine stiff ankles with structural quirks like flat feet, running on hard concrete, and just generally jacking up your training mileage too fast, yeah, you've got the perfect recipe for structural fatigue.
All right, step 4, the clinical examination. Time for the medical interrogation.
When you actually walk into a sports medicine clinic, the doc doesn't just poke your foot and guess. They run through a very strict functional protocol. They'll check out your overall gait, your alignment, and see how you hop or stand on one leg. Then they get hands-on and palpate the exact origin of the fascia right at the heel. Finally, they hit you with the windlass test. They passively pull your big toe back to stretch that fascia. If doing that reproduces your signature sharp pain, bingo, they're heavily zeroing in on their prime suspect.
Step 5, seeing beneath the skin for that hard visual evidence.
Because sometimes physical clues just aren't enough. Now, x-rays are great for bones, sure, but ultrasound. Ultrasound is the ultimate detective tool for this kind of soft tissue. It's cost-effective, non-invasive, and totally dynamic. Doctors can use the ultrasound probe to look right at the fascial tissue in real time, right there at the heel. And they are looking for one very specific smoking gun metric. That metric is exactly 4 millimeters. In a healthy, happy foot, that fascia is relatively thin and tight. But if the ultrasound shows the fascia thickness is greater than 4 millimeters at their standardized reference point, the diagnosis is practically confirmed. The tissue has literally thickened up and swollen due to all that degenerative structural fatigue we talked about. Finally, step 6, rolling out the false suspects.
Because any good detective knows you can't close the case without clearing the copycats. There are a few sneaky conditions that mimic plantar fasciitis. To tell them apart, doctors rely on specific tests and imaging. For instance, a calcaneal stress fracture, a literal crack in your heel bone, will hurt when the heel is squeezed from the sides, and an MRI will light up with bone edema. Achilles tendon issues, on the other hand, hurt at the back of the heel, not the bottom. And then there's Baxter's nerve entrapment. This one is super tricky, but it usually comes with a very distinct, constant burning sensation that doesn't just magically improve with rest. Plus, if the doctor taps the nerve, it causes a crazy tingling feeling.
And speaking of false suspects, we really need to bust a massive myth right now. You hear people blame their foot pain on heel spurs or bone spurs all the time, right? Well, it turns out those famous bone spurs are usually just innocent bystanders. Research actually shows that they typically develop deep to the plantar fascia, not actually inside it. Meaning just because an X-ray shows a nasty-looking bone spur, it absolutely does not mean it's the actual cause of your heel pain. Mind-blowing, right?
So, we've essentially solved the mechanical mystery here. We know it's not a sudden flare-up of inflammation, but rather a slow, sneaky accumulation of damage from mechanical overload, stiff ankles, and biomechanical stress. And clinically speaking, catching this early is a massive predictor for a quick, successful recovery. So I'm going to leave you with one final, absolutely critical question. Are you stubbornly pushing through those early warning signs on your morning runs, or are you actually going to listen to your body before those micro tears become a total structural nightmare? Remember, early diagnosis is your best defense. Thanks for joining me on this explainer, and stay healthy out there.